everyone, and welcome. I'm George McAllister, analyst with NCOL, and I'll be your moderator. We're glad you could join us. Our webinar today is The Health System Perspective, Building Blocks for Population Health. Our speakers today are Meena Bansal, Chief Medical Officer of Mount Sinai Care LLC, and Deputy Chief Medical Officer for Mount Sinai Health Partners, and Lindsay Jubelt, Senior Medical Director of Population Health at Mount Sinai Health System, and Assistant Professor of Medicine in the Icahn School of Medicine. Before we get started, we have just a couple things to keep in mind. Our speakers will be taking your questions via the chat feature. You're more than welcome to send in your questions now and any time throughout the webinar. Our speakers will try to answer your questions at the end of the webinar. If they're unable to, they will be happy to follow up via email. If you would like to receive a copy of today's presentation, you can download it from http://www.healthwebsummit.com/pophealth102016.pdf. Lastly, if you require any other assistance, please connect to the Healthcare WebSummit office at 209-577-4888. Lindsay, we're ready for you to begin.
George, thanks so much for the introduction, and good afternoon, everyone. Meena and I are excited to speak to you about the health system perspective on population health. So our learning objectives for today are to present the challenges and opportunities for delivery systems in a value-based world, create an approach to managing high-risk populations. I'm going to cover those two topics and then turn it over to Meena to discuss the strategies to build an ambulatory quality program across a large delivery system and present some key Mount Sinai case experiences and lessons learned. So just getting started with the challenges and opportunities for delivery systems in a value-based world. So the world is a-changing in healthcare. As many of us are aware, this shift, much of the transformation is being driven on the shift in how financial risk is who is responsible for the financial risk. So historically, we've been in a world where payers have owned the majority of the financial risk. That would be on the left side of this curve, which was published in Health Affairs a few years ago. And what is happening is that we're shifting to the right, where financial risk is moving from payers over to providers and delivery systems, so moving from fee-for-service to bundled payments and ultimately to capitation. This change in bearing financial risk for payers and delivery systems causes us to need to make a number of changes in how we think about caring for our patients. Here at Mount Sinai, which is a large health system in the New York City metro area, our leadership has taken the transition quite seriously and is a big believer in it. And we believe that by taking on the financial risk of patients, it better aligns our incentives to invest not just in the well-being of patients today, but in the long term, and not just here within the four walls of a hospital, but no matter where they are. And so we took a huge plunge in jumping into population health, and our goals were published last summer in a full-page ad that we had taken out in the New York Times and the Wall Street Journal that said, if our beds are filled, it means we have failed. And our goals are to be the most effective population health manager in the New York market, as well as to be the hospital system of choice for population health managers. And so we've taken this plunge, and we're attempting to change our delivery system from a hospital model to one that is a health and well-being model for all of the patients for whom we care. To do this, we've built a new organizational structure for population health, and that is where Dr. Bansal and I work in the Mount Sinai Health Partners. And this is a new department that we've set up to manage financial risk and shift our entire delivery system towards population health. And I've outlined here the number of divisions within this department as a way to share with others how they might think about setting up their own structures. So we have a contracting shop, a clinically integrated network administrative shop, clinical programs, care coordination. We have a commercialization and product line, which is an exciting, unusual space for a nonprofit healthcare system, but this is where we put new products on the market that we think are attractive to other people invested in population health, such as large employer groups and other payers. We have an IT shop and then data analytics. So one of the first areas that providers and delivery systems take on when they think about taking on financial risk of populations is managing high-risk populations. This is a popular topic I'm sure many people have thought about. And this next slide shows triangles that I'm sure folks have seen before, that early efforts when we think about managing our high-cost patients and our high-risk patients focus on the top of the triangle, where we know that a small proportion of patients account for a disproportionate amount of spend. So the top 10% account for about 60% of costs. And this cuts across all payer groups and all different populations and geographies. You see this disproportionate amount of costs taken up by a small proportion of patients. And this idea was popularized in a New Yorker article by Atul Gawande called Hotspotters. And the idea is if we could just find these patients and better manage them, we could save a lot of money. That we know that there's a lot of fragmented care in this country, and things get lost through the cracks, and as a result, people end up in the hospital that may not need to be there. So if we could just better manage them up front, we would save costs and solve the healthcare crisis for America. This is not a new concept to Medicare. So the Centers for Medicare and Medicaid have been involved in thinking about high-risk management programs for some time. So starting in 1999, they launched 7 different demonstrations in 35 programs in 22 states that touched over 300,000 people. There were 3 different types of programs. One type of program targeted specific high-cost diseases. A second type of program targeted high-risk patients that may have had multiple different diagnoses. And the third type of program combined these disease-specific and high-risk patient programs together. So a lot of attention and energy has been put into this. And the results to date have been fairly interesting. So in 2009, Deborah Peaks came out with an article in JAMA that looked at 15 randomized controlled trials of these programs. Of these 15 programs, only one reduced hospitalization rates, but that program increased healthcare expenditures by 10%. And then after factoring in program costs, none of these 15 programs led to any savings. Then in 2012, another article came out looking at 34 of these programs. Again, all of these programs sought to achieve savings by focusing on care coordination and reducing unnecessary hospital administrations. However, on average, the programs had no effect on hospital admissions or healthcare expenditures, and after factoring in program costs, none led to savings. So fairly disappointing results after a very robust effort touching many patients on these high-cost hotspotter programs. So why hasn't it worked? And there are a number of different hypotheses for why this approach hasn't worked. One is that perhaps the assumptions about unavoidable care are unrealistic. Perhaps outreach strategies are a poor fit with the population. Maybe our intervention strategies themselves need refinement. Maybe usual care has improved, so when you look at these randomized controlled trials, maybe the control group has just gotten better, so there's less effect size. And then finally, maybe we're not targeting the right patients. And so I'm going to focus a little bit on that because that's how we're starting to think about refocusing our efforts as we move into this world of population health. So one interesting thing to note about these high-cost patients, and this is a little counterintuitive to how many of us think about it, is that prior costs do not predict future costs. So this data comes from internal data of a United commercial population where I had looked at the top 1.25% of member spend in year 1 and then followed them forward into the second year. No intervention, just completely observing a natural course of progression of the top highest spenders of a population. And as you can see here, whether you look at the top 1.25% or the top 2.5%, the spend goes from about $135,000 in the top 1.25% to about $60,000 in the second year. So you've got a regression of about 56% in cost doing absolutely nothing to the population. We call this regression to the mean. I'm not the only one to have found this. There was a great article in Health Affairs last summer coming out of the Denver Health Group where they looked at their population of superutilizers. And these were defined as members who had had 3 or more hospitalizations in the past year or 2 or more hospitalizations plus a mental illness. And they looked to see what happened to these members over time. And the bar on the left shows the whole comprehensive group of patients. And what you can see here is that the orange part of the bar, those are folks that are in the original superutilizer group that die. The blue are folks that met the criteria of being a superutilizer, but over time are no longer superutilizers, so they regress back to the mean. Yellow are in the cohort who lose their superutilizer status but later regain it, and then the pink at the very bottom are those that retain superutilizer status. So over a 2-year period, only about 13% of patients remain superutilizers. This is a huge change in how we've thought about superutilizers historically and creates a number of problems for the traditional ways of managing high-cost patient populations. A lot of the ways that we feed our engines in terms of identifying high-cost patients, the data is quite delayed, 3, 6, 9 months. Well, if we look at this data, what we see is that by the time we identify who those patients might have been, they're no longer in that superutilizer group. So why is this a problem? It's a problem because without realizing this and changing how we approach our high-risk populations, we're going to invest resources and very expensive resources in the wrong patients. So how can we do this better? Well, we have 3 suggestions: 2-hit hypothesis, segment the population, and know when to let go. So the 2-hit hypothesis. This is the idea that just because you're come up on a risk score as being a high-risk patient, you are not necessarily right now high risk or can benefit from the intervention. Instead, you need to have some sort of underlying risk score and then a critical event that we can act upon. In order to find these critical events, we've got to redesign our data systems to provide surveillance system to identify critical events when they happen. And those data systems come from multiple places. One of the challenges with our data prediction models is that they often rely on claims data or just clinical data. We know that a lot of the variables that predict healthcare utilization in the future come from many other data sources, such as psychosocial data, patients self-identifying that they're having an issue. Physicians themselves have shown when they try to use their own clinical gestalt about who's going to be high risk or high cost in the future, there's evidence that they can outperform some of the traditional claims-based models. So we need to incorporate more data, but more importantly, we need this data to be real-time and actionable to indicate when an event is happening that we can act upon. A hospitalization is a great indication of that, perhaps a new diagnosis, or when a patient or family member calls and says, I'm having an issue right now. We need to be able to set up these surveillance systems to figure out what are those critical events, how do we recognize them, and how do we transform our delivery systems to act on them right now. Because this idea of relying on data from 6 months ago to identify high-risk patients just isn't going to cut it now that we understand that our high-cost patients of yesterday are not our high-cost patients of today. So this 2-hit hypothesis, what is your underlying risk score, and then how do we find that next critical event that we can act on is one suggestion in the way that we're trying to transform how we manage our high-cost patients. The second suggestion we have is to segment the population. The marketing world has been doing this for a long time. In healthcare, we're slowly getting there. And what we understand is that there are different clusters of high-cost patients. There are many different ways to segment a population. I've put up an example here of one basic way to do it, which is to just separate costs between hospital care costs and outpatient care costs to illustrate this point. But there are many other different types of variables that could be put on these axes. So when you think about segmenting patient populations by these costs, you can see that there are different populations that start emerging. So those patients that have just high hospital costs but not high outpatient care costs, maybe a person who has a traumatic event and spent a long and expensive hospital course, but may not be using expensive outpatient care. Similarly, we may see some of our psychosocially complex patients pop up here where there are some types of patients that don't engage in the outpatient world but continue to come back to the emergency room and the hospital. Some of our folks that are high on outpatient costs but low on hospital costs may be some of our folks with chronic diseases that are expensive and predominantly managed in the outpatient setting, such as cancer or autoimmune conditions. One of the things that helps us once we start breaking out these populations is that we realize that, again, we can't go back to that traditional triangle and just manage all of these patients the same just because they're high cost. What we need to do is recognize that there are different types of populations that require different types of interventions. So the traditional care manager intervention to manage a patient who's a frequent flyer to the hospital isn't going to work for those patients who have expensive outpatient chronic diseases. So we need to think about what are our patient clusters, segmenting them, and matching up appropriate interventions. One of the additional things that we've thought about is selecting 5 criteria for population-level interventions. And I realize that this slide has functionality on it that I won't be able to highlight it, but I can just speak to it. Underneath are some hidden boxes that the automation will pull it away. So when you start thinking about your segmenting your populations, what are the ones that you want to go after? So you want to go after an area that is high cost. Second is that you want to be able to be able to predict who's going to be high cost in the future. A great example that we're working on now is patients with chronic kidney disease that are at high risk of progressing to end-stage renal disease. So we know that that transition is extremely expensive, but if better managed and dealt with ahead of time, you can result in planned transition to renal replacement therapy that results in lower costs and better outcomes and lower mortality rates to patients. You want to figure out, do you have a high-cost patient population? Can you predict who is going to go through that high-cost event with fair accuracy? Do you have an intervention, third, that you're able to see results that you know will be effective? Fourth is, can you figure out if those results will be turned around in a relatively short period of time? So one thing that's important for getting buy-in from any delivery system or anyone that's going to be paying for these interventions is that the time horizon can't be 15 or 20 years. Folks are going to want to see return on that investment, so you need to see a short time horizon for those for those results. So those are the criteria that we would recommend for thinking about once you've segmented your population. How are you going to pick where you're going to focus? So, is it a high cost intervention? Is it a high cost population? Can you predict who's going to be high cost? Is it an effective intervention? Can you see results in a short time horizon? And then finally, is that population large enough? So it's not just that you have 5 high-cost patients with that disease. Do you have enough of a sizable population that it makes a difference? So those are the criteria that we're using to think about where do we focus our energies. So then the last point I'll make about managing high-risk patient populations is knowing when to let go. So for those clinicians on the call, I'm sure many of you have worked with patients where you've invested a ton of energy and time into continuing to try to make them better, continuing to try to better manage them, and they just are not engaged and not responsive. There is a point where we need to say this patient isn't ready to engage or this isn't the right intervention for them. And a good 2x2 table here is the cost versus responsiveness. So we have some patients who are low cost and low response. We don't want to be engaging them because there's not going to be any return. They're low cost anyway. There are some patients who are high cost and high response. Those are absolutely the right target to go after. But often we get caught up in this top left corner where we're high cost and low response. We continue to pour resources into a patient, but they're just not responding. And I think as we are getting better at this, we're starting to set limits to say, how long do we engage without success before we say, okay, this isn't working at this time for this patient, and we're going to turn our resources elsewhere. And I think this is an important area, not just to say, how do we predict for whom we're going to manage, but also how do we decide when we're going to stop managing them. And we need to do that so that we can bring in new patients that are going to be responsive to the intervention. And this is a key area that we've now started pushing on to make sure that our interventions are targeting the right patients at the right time. So that's an overview of how we're transitioning our thoughts around managing high-cost patients away from the traditional model of just managing the top of the triangle to thinking about new ways that will be more effective. So the 2-hit hypothesis, managing patients who have high risk to begin with but then have a critical event. Second, segmenting the population and understanding there are different types of clusters of patients, and we need to design interventions to match the needs of those patients, and then using the 5 criteria to figure out what types of interventions to focus on, and then knowing when to let go and setting clear parameters, not just around predicting who we're going to let into our care models, but also when we're going to discharge them and move on. So I'll turn it over to Dr. Bansal now to talk about a whole other area that we're working on, which is building a quality program across a large delivery system.
Great. Thanks, Lindsay. Let me see. I have the controls now. Okay, so welcome everybody. So switching gears a little bit, but I think you got the sense that we are a very large health system encompassing 7 hospitals, over 300 community locations, and including about 2,300 full-time faculty and 1,000 voluntary physicians, and this number continues to grow really by the day. And while our system has a robust inpatient quality program, we have just really begun to build a robust ambulatory quality infrastructure. And so, some of the basis for this is the increasing number of quality contracts that we're involved with. And this is just to give you kind of a directional idea. We have about 250,000 lives in value-based contracts ranging from commercial, Medicare, and Medicaid programs. And these vary from being straight pay-for-performance types of programs to those that have a shared savings gate that then opens up into quality programs. But as you can imagine, the different quality metrics that the payers have given us can be quite ranging and varied. And so what we've tried to do to try to get a handle on this is develop our prioritized quality matrix based on the value as well as the commonality across multiple contracts. And so in some cases, the 4 or 5 star are kind of published rates, but in some cases we developed our own 4 or 5 star ratings based on targets within different contracts. And in some contracts, these measures are triple weighted, and so that is bolded so that we pay particular attention to those. And so we've developed kind of a strategic timeline. So in the beginning of the year, naturally, we try to tackle all high priority gaps, and we try to get patients in for their annual well visits. But as the calendar year progresses, we have to start to become more strategic, focusing on where success is possible, where are we relative to the target rate, and what is the likelihood that in a given contract that we might get shared savings. And so we don't know oftentimes until later whether at all there's a chance to have shared savings, which then opens a quality gate. So it's really towards the end of the year that we can start to become more strategic, and I'll share some of the tools that we've developed to try to help us do that. In addition, at the end of the year, we also try to reach out to Medicare patients who haven't had any visit thus far this year so that we can take advantage of any potential coding opportunities as well as addressing quality gaps at the same time. And so our global strategy also differs between whether we're dealing with our employed doctors versus our voluntary doctors. But essentially, focuses on our ability to be able to schedule appointments for the practices, in which case we might have a different approach. Our approach varies based on the level of engagement of the providers and the practices, as well as their relative patient attribution in our high-value contracts. And so for our employed physicians, in many cases, we have centralized access to their scheduling systems. And therefore, what we've done now, and I'll give an example in the next slide, is we've actually married the appointment scheduling with documentation or quality gaps. And so this kind of patient 360 we provide to providers and practices a week before the patients are actually coming in. So the patients have a scheduled appointment, and then we pull any quality gaps or potential coding opportunities that exist for that patient, and we provide it to the practices in advance. This allows for pre-visit planning, and that way practices or providers don't have to look at any separate reports or portals that they might be getting from this payer or that payer. It's all payers that we're providing if those patients have a scheduled appointment. This is also bidirectional, so this gets shot out from one centralized email. And it also goes with a spreadsheet. As you probably know, if you're doing any work in this space, oftentimes gaps may have been closed historically, but if the claim didn't hit or if it was done like a colonoscopy when the patient had a different payer, it might not be recognized. So this allows for the practices to send back to, again, one single email any historical gaps that may have been closed, and that way we can kind of hold on to that in a centralized source to allow for the submission of encounter or supplemental files to payers to kind of get credit for those those quality targets. And again, in the fourth quarter, we start to get more strategic, depending on the proximity to quality target rates and the relative patient attribution in a given practice. And so this is just an example of what we call our Patient 360, and it's just the start. We envision this 360 to grow over time to include things like patient-reported measures, but the practices will get for each patient a form like this that will have any kind of coding opportunities if they're a Medicare patient, as well as any quality gaps. It'll have their risk score and a potential score increase by closing the coding opportunity. For our voluntary physicians, we do not have access in most cases to their appointment scheduling system, and so there we have to really just provide patient-centric chase lists. So it's at the provider level, so Dr. Smith might have 10 patients that are in a particular value-based contract. So all the gaps in care for that particular patient will be lined up with them. So it's not just here's a colonoscopy chase list. It's what does Mrs. Smith need? She needs these 4 things. And that provides the practices an opportunity to, if those patients don't have an appointment, get them in for an appointment and close those gaps at the point of care. And then again, we get more strategic as we get towards the end of the year based on the current performance of a practice in a given target and their patient attribution. So how do we get strategic? Oh, actually, before I go to that, but then in addition to kind of directed approaches at the practice level, we also have now a monthly ambulatory quality work group, which includes chief medical officers and medical director level leadership, both from employed as well as voluntary practices. We hold multiple town halls and webinars so that we can educate medical directors and practice managers to different care gap opportunities and just provide an overview of our approach, elicit feedback and questions. We also, our quality group, will go out and attend faculty meetings and practice manager meetings to again outline strategy and approach, as well as quarterly visits to all of our voluntary practices. But what we've developed is really something that we call an opportunity finder. And what that allows one to do is start to look strategically at how we're performing. And this is this is being developed right now, and this is really just for kind of sharing with you all. It doesn't have necessarily all the data there. But basically it breaks down by payer, by contract, all the different quality metrics and allows us to see where are we compared to where we want to be at the end of the year after all the reconciliation is done. So we can see green, we're already at the 5-star target rate, or are we red and we need to do some additional work. Then this is all drillable. This can be, you can focus on any particular measure, develop Excel spreadsheets that will provide targeted chase lists. And so what we do, say we're looking at a particular measure, in this case breast cancer screening. The larger boxes reflect the groups that have the larger patient attribution for this particular measure. And you can see they're in green, so they're doing great. But as you move to the right, we can identify which practices have opportunity based on their size of their box or their patient attribution and where they are in the spectrum of red to green in approaching a particular target rate. And so we can do this, you can really slice and dice this. It's a Tableau platform that was developed by our IT data analytics team under the direction of Mike Berger and Caitlin Dugan. And so this has become really something that even a medical director can go in and look at their practice, and it generates Excel spreadsheets with targeted chase lists. And so in summary, the main features that are really essential to developing a robust and successful ambulatory quality program, well, of course, we need physician and staff engagement. And so trying to be available and present in a number of meetings helps with that. Centralized data to allow for tracking of performance across practices and payers really allows us to have that strategic focus. In addition, having centralized support to schedule appointments. So for example, what we're doing now is if MA patients haven't yet had a PCP visit during the calendar year, Our centralized call center is reaching out to those patients and scheduling them for appointments in their practices. Once they're scheduled in the practices, the patient 360 will come out the week before and share with the providers in the practices any potential coding or care gap opportunities. And so really this is just the beginning for us, but we really want to develop the proper pipes and the infrastructure so that we can be successful in these value-based contracts, which as we all know will only increase over time. And with that, I think we're at the end.
We'd like to take this opportunity to thank our speakers and all of the participants for joining us today. We'll be sending a follow-up post-event feedback via email before close of business today, and we'd love to receive any feedback you wish to share. If you haven't already done so, please be sure to join our LinkedIn group on the web where you can post questions, start discussions, and suggest topics for future events. This now concludes our webinar.